start. First presentation of the STEMI report, which is supposed to be Brenda. She put it together, but it's going to be me. She's over here. So I'm going to go start on this. EMS run, it was 10:08, dispatched to a rural residence for 75-year-old male having chest pain and carbon monoxide exposure. At 10:17, they arrived to the patient, conscious and alert, sitting on a couch, complaint of substernal chest pain. Sharp at a 6 out of 10. Safety onset is about an hour prior to calling 911. Past history of MI and stroke states he has an iced over chimney at home, allowing carbon monoxide to escape. Not allowed, excuse me. Detectors went off and they opened the windows and left the residence and went to a residence where EMS now picking them up at. Pretty smart. 10:26, they had 12 leads with ST elevations in lead 3, AVL, AVF, B1 through 5. Attempted to transmit a 12 lead to Union without success. Administered 324, chest pain improved to 4 to 10 with just aspirin. 10:27, vitals under 87 over 48, heart rate of 79, respirations are 18, O2 saturation 98% on room air. Blood glucose of 173, they have an 18 gauge left AC, 500 bolus administered for hypotension. Nitro obviously was delayed due to hypotension. 5 minutes later, they got an 88 over 51, so it's not going up a ton, 75, 18. Pain at 4 or 10, bolus will continue. 34, they've got 2 liters of O2 via supplemental use and also possibly to help with some chest pain. And the BP at 10:36 is 86, so we're actually going in the wrong direction. 86 over 53, heart rate of 73, fluids continue to wide open. 10:43, BP is reassessed, still slightly hypotensive with systolic in the mid 90s. Placed a new bag of fluid. So now we went through 500 and we're in the second, to another 200 given. STEMI alert called to Union with ETA of about 10 minutes. At 10:45, blood pressure is a 109 over 66, heart rate is 68, respiration rate 18. Pain still 4 to 10. They now decide to give the nitro 0.4 milliliters. Milligrams should be sublingual for chest pain. Fluids continued at KVO rate at this point in time. At 53, they arrived and transferred into the ER trauma 3. ER doctor was waiting in the room along with multiple nurses. Doctor confirmed STEMI, report care was given to staff. ER assessment, carboxy hemoglobin was 27.4, placed on non-rebreather and away to cath lab. 11:31, patient arrived, procedure room 59, balloon catheter advanced to target with vessel. At 12:25, the stent advanced to the target vessel, successful stent, LAD with 100% to 0. Pretty amazing actually. Daughter balloon 6 minutes. Sustained DTAC with 48 hours within 48 hours of the STEMI. The patient was discharged 5 days later after the STEMI with severely reduced ejection fraction of 15 to 20%. Has a life vest for 40 days. If EF remains below, the recommendation would be a dual chamber ICD for primary prevention. Interesting case, especially with adding the carbon monoxide on top of that. It just probably never really helps a lot. I'm not sure about the 98 to 99% O2 saturations, where that was, if that was, because it could have been not necessarily all oxygen to begin with, makes sense. Today, the year date for last year, we had a 97% door to balloon time within 90 minutes for the fallout in April and May, but everywhere else we've done a really good job. So thanks, Brenda, for the report. And any questions or anything from anybody? Any thoughts from anybody on? It's interesting. A lot of fluid given. All right. Next thing is going to be stroke. It would be Beth Harrison, but hey, it's going to be me. Beth's husband had a procedure and she was not going to be able to make it today. So this one, guys, I apologize right up front. I have not even, I looked at it, put it together, but I don't know it. So history is a 78-year-old female. Prior history of TIAs, DVT, HPN, cabbage, stage 3, renal disease, and not very sick at all. So anyway, SP radius, ulna fracture, open reduction of the left wrist 6 days prior to this. Husband witnessed fall of approximately 2 feet onto a carpeted surface and states the patient did not hit her head. Last known well time approximately at 12 noon. They were notified at 12:06, arrived at 1:07, en route at 12. Arrived at 12:15, departed the scene at 12:26, arrived at Union at 12:34. So from the time they were notified, the land was 28 minutes. Oh, that's right. Patient appeared alert and oriented, had right hemiplegia, right neglect, right facial droop, slurred, garbled speech, but would shake head yes and no appropriately. Glucose not obtained. Okay, patient was an AFib, BP of 142/62, got a respiratory rate of 18, O2 saturation 98%, and GCS of 15. Okay. Stroke alert was called on the IHERT, and a patient went from CART directly to CT3. At 12:48, the CT head without contrast completed with no bleed present. An IHSS 19 in the ER. Decent. Okay, pretty high. All right, patient evaluated by TNR and TPA is advised. TPA was given at 13:07, 29-minute door to needle time. Patient was able to say yes and no after TPA infused, but then speech returned to garbled state. 14:13, the CTA CTP performed and ruled in large vessel occlusion, positive for an occlusion in the distal segment of the MCA. Small acute core infarct in the left frontal lobe with surrounding ischemia nubria. Candidate is for mechanical thrombectomy. All right. So the disposition at that time at 16:14, the patient was transferred via air to St. Vincent's. Mechanical thrombectomy for M1 occlusion performed by Goodman Campbell Associates. Outcome: the patient developed a small SIH subarachnoid, unable to restore full circulation. Stroke evolved into including parts of the frontal and temporal lobes. After 15 days, the patient was transferred back to Union Hospital for medical rehab. Patient was a max assist of 2, remained aphasic, right hemiplegia. Spent 3 weeks in our acute rehab, then transferred to a SNF for continued rehab. Great outcome. Contributing factors to this: cardioembolic stroke. A patient with a long history of AFib, which is not a real, if it's not controlled, it's not great. Prescribed Eliquis, but stopped after taking after the GI bleed. Was medically cleared by GI, but refused medication. Took aspirin 81 daily instead. Highlights. Great, she says excellent EMS documentation, the history obtained at the scene, last known well, and no anticoagulation. Stroke alert was called. Van and Cincinnati scales reported as positive. I like the idea that they did both. That's great. That's what we can tell. Direct to CT and no finger stick blood sugar obtained. Kind of need those numbers, right? I mean, that's one that we definitely would need to have. So that's why I questioned it when I read that. So, any questions, comments? Anybody has comments on that? All right, so the next up is I actually get to stop talking now. That's awesome. No. I'm going to introduce Will Losey. Will's going to do Union Hospital Clinton's reports. So thank you. Hi, guys.
Yeah, I think so. I did keep it shorter this time. It was pretty painful getting through 4 checks last time. One Ileana run.
Trying to iron out the details for that.
First case study, 74-year-old female, history of hyperlipidemia and a smoker. She called 911 for chest pain that was radiating jaw, back, and both arms. EMS 25 at 4:07 arrived at 4 morning at 4:37 and arrived direct to Union Hospital Terre Haute at 5:07. Patient was able to talk to EMS upon arrival, answer questions appropriately.
Will. Talk louder.
Talk louder.
There we go.
Thank you.
Thank you.
Then you're buried. Yeah.
Easy now.
Of course. Patient's friends stated they'd given 3 baby aspirin orally, deep, warm, and dry, pearl, complaining of mid-center chest pain, radiating into the jaw and both arms. This woke her from her sleep about 3 o'clock that morning. I was also complaining of nausea, denied any shortness of breath, dizziness, vomiting, or diarrhea. Patient denied any medical history, no medications. Was able to walk out to the ambulance with minimal assistance, normal gait noted, placed on a cardiac monitor, 12-lead EKG obtained. Initial blood pressure of 124/54, heart rate 65, respiration 16, sat 97, 20-gauge IV established, left AC, 12-lead EKG obtained, showing a sinus rhythm with ST elevation in leads 3 and AVF, no reciprocal depressions noted. Rating of pain out of 3 out of 10. A second 12 lead was obtained, showing the same elevations. Despite previously saying no medical history, we have them then saying that they've got a 50% blockage in their arteries, but no stents placed. They continue to monitor vital signs, Still complaining of nausea, so they gave 4 milligrams of Zofran at that time, finger stick at 135, no nitro given. They did 3 more 12 leads en route, and they did note elevations in 3 AVL as well as AVF and B2 with the last one. Iron report given to Union ER. Patient arrived 1516, EKG 1 minute later at 5:17, cardio consulted at 5:23. Patient was taken to the cath lab, found to have 100% occlusion of the RCA, ballooned open and stented. Echo of the EF of 60. Observed in ICU, discharged home the following day. Door to reperfusion of 78 minutes, first medical contact reperfusion of 130. So this one, I like that they went directly to Terre Haute with recognition of the ST elevations. I forgot to put it in this slide, but those serial EKGs are fantastic as well, monitoring for that evolution of the MI. I did not note though in the EMS report or in the Union EMS report sheet that the recipient was called. Must give me alert, I should say.
You don't know if they did or not.
I don't know if they did or not. Our second one, we have a 62-year-old male. Histories of seizures, CVA, neuropathy, COPD, kidney disease, taxi gait with a wheelchair, high cholesterol. 911 was called by family when they came to his house and found him down on the floor with an altered mental status. EMS at 1704 arrived 1707, departed 1716, and arrived also direct to Union Terre Haute 1735. They were dispatched to the residence for a sick person, arrived to find the patient seated in his wheelchair. Family states they found him on the floor of the living room at 10:30. They put him back into his wheelchair, but they continued to note he had some decreased LOC with confusion, which is what prompted them to call 911. I did have a history of previous CVA with left-sided deficits. Complaints, some symptoms of left-sided weakness with slurred speech, unsteady gait, and weakness. Complaining of pain in his buttocks. Unknown if there was a loss of consciousness with his fall. Denied nausea, vomiting, diarrhea. Assisted him to the cot, secured him down. En route, showed sinus tach. Vital signs were reported. IV 20 gauge, blood glucose of 140, and transported to Union Hospital Terre Haute for family request. A level 2 trauma alert was called upon arrival. Patient had been found down on the floor with an altered mental status. CT of the head was concerning for acute infarction. Patient was not a candidate for TPA due to the unknown onset. MRI of the brain did show acute infarction. Right mid posterior MCA territory involving the right parietal lobe. They did do CT, C-spine, L-spine, and pelvis. Since he had fallen, all were negative fracture. Cardio and neuro consults were completed as an inpatient. Started him on Lipitor, PT, OT to see and treat. Low nitro prolactin at an echo. That was at 50 to 55%. Speech therapy eval was done. Patient was cleared for a soft diet. Had an event monitor placed. No history of AFib. They wanted to rule that out as a potential cause for his CVA. And he was eventually discharged for rehab at a local facility. On this one, I did not find rope scales. They didn't have an NIH in the ER until 2400 in the ED. Unfortunately, they did give aspirin prior to swallow eval being done in the ER as well.
Any questions? Anybody have any questions for Will? Thank you, for sure. Thank you. Next up is going to be our trauma report. Tina is going to come and do our trauma report for us. She's so excited to, I promise.
Favorite part of her job.
It is. Liking it better every day.
I love it.
Just you didn't.
Morning. So we've got 2 cases to talk about. They're both open fractures. This first one is a 55-year-old male. It was an assault. 911's called 10:05, dispatch 10:09, en route at 10:10. On scene 10:16. They departed at 10:30 and at Union ER at 10:46. So the total call time from the call to arrival at ER was 41 minutes. The EMS report stated the patient was assaulted the night before. He was assaulted with a baseball bat or some kind of pipe, he said. Denied loss of consciousness, said that he was drunk and he just went to sleep. So he was alert and oriented on their arrival. He had injury to his right lower leg. They did document that he had an avulsion to the right lower leg. There was no bleeding. They put on a Band-Aid and they didn't call a trauma alert. But he was up walking around. Pre-arrival note from the ER said there was a right shin avulsion. He wouldn't bear weight. They got to the ER at 10:46. He complained of generalized pain, worse than the bilateral lower extremities from being hit with a bat. Abrasion with a linear laceration over the right distal tib fib. He was moving all of his extremities, neurovascular was intact, range of motion, sensation, and his pulses were good. Vitals were stable. There was no trauma activation called. This was what his leg looked like. It was a 3 to 4 centimeter open wound. A diagnostic said x-rayed the right tib fib, showed a mildly displaced oblique fracture of the right distal tibial diaphysis. X-rayed the left tib fib, CT of the head, chest x-ray, left hip, and labs and drug screen. So this is a picture of the x-ray, little jagged fracture, just mildly displaced. So the diagnosis was a right grade 2 open displaced tibial shaft fracture. His drug screen was, of course, positive. Tetanus was given. Cefazolin was ordered at 15:36, but it wasn't given until he got to OR at 17:15. He was admitted to the hospitals with ortho consult. He had to have cardiac clearance because of his history. He had an echo back in October that showed an ejection fraction of 30 to 35%. Apical kinesis on large apical thrombus. He went to emergency surgery for right tib fib irrigation debridement for an open fracture and right tibial nailing. So this is our trauma criteria, the activation criteria, and as you can see, any open long bone fracture is automatically a level 2. He stayed, and first day he was having a lot of hip pain, so they did a CT of the chest, and he had a non-displaced fracture to the left iliac bone and some swelling of the muscle. He was given IV pain medicine. They started him on cardiac meds for his reduced ejection fraction, continued the IV antibiotics for 24 hours, and he was no weight bearing. Day 3, his pain was better, but they were waiting for PT/OT to see him. Day 4, they recommended sniff. Case management was following him, and of course he was a pre-cert, so we had to wait to get that approved. It was discharged, okay for discharge from ortho and cardiac with follow-up. Day 5, pain was good. They were just waiting for approval for the sniff, and day 6, he discharged to the sniff. Got anything on that one? No, we'll go on. No. They,
Hang on, Tina.
Oh, sorry.
Eric has a very good question. Why did we not recognize antibiotics in the field?
Yeah.
Because it is in their protocol.
I would have asked a question.
I mean, we have an open fracture.
I
It's in it.
think they get focused on the fact that the bone is not sticking out, and that is pure theory.
And we're gonna talk about that.
Just curious.
Yeah, I think it was a small laceration, but it was right at the fracture site. So that's a good question. The second one was a 34-year-old male. I was here for this one, so I remember this guy. MVA with entrapment. 911 call was at 7:58. Dispatched at 8 o'clock, en route at 8, on scene at 8:06. They left the scene at 8:27 and was at the ER at 9:08. Total time from the 911 call to arrival was 68 minutes. EMS report said that they found the patient standing by a passerby's car. He was refusing treatment initially. There was a language barrier. He was Hispanic. Police was on scene on arrival. They questioned whether he was intoxicated. There were smells of alcohol, and there definitely was. The EMS report said that there was blood dripping from his left arm with a noticeable deformity to the left arm with a laceration. They applied a SAM splint and trauma dressing. He walked to the ambulance. Vitals were stable and the GCS was 15. This was the IHERN report. It's kind of hard to see, but it said chief complaints MVA rolled multiple times, what this says, and that he complained of fracture of the right arm, and then in quotations it says couple. So I'm not quite sure what that meant. On arrival in the ER at 9:15, they did call level 2 at 8:58 when they got the IHERN report. GCS was 15. He was refusing to give details. He laid there almost kind of catatonic, and we kept asking him, "Are you hurting? What's good? You know, what happened?" And he just, no matter what we did, and finally somebody just kind of had it with him. They said something to him in Spanish, and he's just like, you know, like, well, that works too. Anyhow, he was denying pain. He was the driver of the car. He's suspected to be intoxicated from alcohol. He ran the car into a ditch. Vitals on arrival 91/67. Pulse and rest were okay. His blood pressure improved with fluids up to 103/77. They did a fast, it was negative. Diagnostics, they did labs. The CT of the spine showed an acute fracture with of the inferior aspect of the right superior articulating facet by C5. It was mildly displaced. He was having some muscle spasms. CT of the head showed a superior scalp soft tissue swelling without fracture. The CT of the chest showed a fracture of the distal left shaft of the humerus. And then on the humerus, it was an acute transverse fracture or transverse fracture with marked displacement of the shaft of the left humerus. And that was 11 centimeters above the elbow, and they x-rayed his hands. So his diagnosis, cervical spine fractures, fracture of the humerus, laceration on the left upper arm, MVA, alcohol intox, and he did have microscopic hematuria, but the fast was negative and the CAT scan didn't show anything. They gave him IV antibiotics, tetanus at 9:38, so the time was good. Zero foam was applied over the wound, a long arm splint, and then the patient was transferred to St. Vincent Indy at the recommendation of Dr. Stefanian. So this is just a little bit about open fractures. We're really trying to focus on catching these open fractures and making sure we get the antibiotics in time. Open fractures are just fractures with direct communication to external environment. It could be as small as a centimeter if it's near that fracture site. I'm not an ortho nurse, never was, never wanted to be, and so I've learned a lot doing this review because to me, an open fracture was always a bone sticking out, and that's not the case at all. Diagnosis made by assessing the size and the nature of the external wound, as well as taking x-rays of the bone at the location of the soft tissue injury. Treatment will depend on, of course, the location of the fracture and what kind of fracture, but they do have to have immediate IV antibiotics and urgent irrigation debridement, followed by surgical fixation. So this is our trauma management guidelines. You can see the response time is supposed to be 60 minutes or less from arrival for IV antibiotics. Patients with open fractures have to receive those. We have inpatient and ER order sets for the antibiotics. Within 24 hours, tetanus needs to be given if it's needed, operating room for irrigation debridement, and within 7 days, grafting or whatever else they may need. So this is the Gustillo. I think I misspelled it. It's 1L, but this is the classification for open fractures. There's another little page that shows this a little better. And we got some pictures, but it goes from 1, 2, 3, ABC. So it goes from just a very small wound of a centimeter or less, all the way up to a major injury causing vascular and major tissue damage. So these are pictures or examples of open fractures. The one on the upper left is a 1. It looks just like a little cut, but you can see there's a little swelling, a little bruising. But you know, some people seeing that may not think it's an open fracture. But I think one thing too to point out is you have to look at the mechanism of injury. Was it forceful enough to cause a bone fracture under that laceration? The right upper is a 2, so they've got some avulsions there. Three is, that's 3A on the lower left, and you can see the bone sticking out. And then the lower right is a 3B. You can see the bone and tendon and the tissue has been torn away. And then this is the 3C. This is a mess. And he had an injury to the other leg too. But you can see the bones sticking, tendons, and massive tissue damage. This is going to have vascular repair and a lot of skin grafts and stuff. So that's all I've got. Does anybody have any questions or?
Yeah, is there like assessment tips to better assess the smaller type of open fractures that were more commonly missed?
Address that?
So the laceration does not have to be caused by the bone to be considered an open laceration. I think way back in first responder days, and some of you guys weren't even born yet, where they did teach you that unless the bone wasn't coming through, it's not an open fracture, compound fracture. So there's a difference. And I think it's not as much figuring out how they got the lac as much as knowing it's open and it's broken.
So, agreed, and I would piggyback to that, to the thought process, and I would lean towards, I understand if you have just a small laceration, unless there's deformity known, we can't say it's broken, right? Because I don't have X-ray vision.
Right.
Idea is, do we just treat mechanism injury, laceration, consider it to be an open fracture, and give them, if they're not allergic and don't have a problem with giving them the antibiotics, do we lean that direction? And maybe we should. Maybe we truly should lean that direction for our patient, because I'm not saying for the trauma. I mean, the trauma can meet their standard, but if we give that antibiotics in the field, then that standard's met. All right, and we're also doing the best that we can for our patient. So
Is there
maybe
any
the
doubt
thought process.
Is there any negative for that?
No, I don't think, unless they have an allergy to to any kind of antibiotics or something, I don't think there's any way you're gonna hurt that patient by
One
giving them
dose
this.
of antibiotics, you're wrong.
So I heard.
Yes, one dose of antibiotics is
Not
not
gonna
gonna
hurt
hurt you guys.
I agree 100%.
We're giving what, 2 grams? I
That
think
helps.
Yeah.
for the 3 grams, we're giving less than
For the
120.
mice and if
And then
you
3 grams.
complication, big, big boy.
Yeah, if you're big one, you're 3. So I mean,
Yeah, and so the thought process is that one round of antibiotics is going to hurt, but is going to help, but it isn't gonna hurt. I
Because
mean,
the standard is for us in the ER. It's
Right.
60 minutes from the time they arrive. So the fallouts come to us. We
Right.
have to own the fallouts.
our goal is to be what best we can for our patient. And so maybe recognizing there's an open, there could just be a small laceration, may not be a break in there, I don't know that, but if I have a.
I think
injury
the.
that Have an
you don't have to-
have a
I
deformity
think
noted,
the
that's all.
leg deformity, but the arm didn't, or
They
vice
said
The
that
arm did, the leg
did
did
like
not.
Yeah.
one of them was deformed, one was not. So
Did they-
I can see not catching that.
didn't it state that he was
Walking on it?
Yeah.
So I mean,
No, he couldn't bear weight.
well,
Yeah.
But at the scene, he was walking on it.
Yeah, that's crazy for a complete fracture like this.
So does that help you, Arlington, a little bit answer your question? I mean, I think if we err in the judgment of our patient, give it. I mean,
But do you think in general that the medics are gonna think about that? Like, this is kind of a different group here.
Well, in general, if there's 18, 20 people on there, the thought process is very simple. We carry antibiotics in the field for open fracture.
I would say we don't see them often.
you say we're probably underutilized.
Yeah,
Yeah,
we really
that's what I was
don't.
getting ready to say. I said, I don't think it's given enough. For the many times that we have seen, I'm pretty sure that we could give it more as EMS professionals. Just that's. and
Because
that
it's
is-
dirty. These people go to surgery, they go for washout.
Given that ahead of time, they're gonna get it cleaned up anyway.
I just wasn't faulting you for not giving it.
No, I'm not faulting that.
With the
That's kind of where I was going back with,
stuff and-
leaning towards the medic, I can see why they didn't. I mean, I can
Yeah,
literally
one
see because I
was
can't.
deformed,
go
one was
through.
not, but he walked on it.
But you've got one that's bleeding, that's deformed, that to me.
Oh, yeah, that's obvious.
It's a little more obvious, I think.
All right, so our last presentation, thank you, Tina, very much, appreciate that. Our last presentation is going to be Dr. Zach Worley. He's going to talk about stroke review, EMS audit review for us, and Zach. All right. Sorry. Okay, this is, nope, that's, doesn't work. It's squirrely.
All right, so we're just gonna spend a few minutes talking about stroke. I'm gonna blow through some of the boring slides, and a lot of this is not necessarily anything you need to know or even in some cases, I even need to know. It's just kind of interesting to know about the anatomy of stroke and those sorts of things. And then we'll touch just on the, the presentation of stroke, the recognition of stroke, the treatment. I have to say, I am pretty, confident in all of your guys' ability to recognize stroke. I, anecdotally, find you guys to be very good at, calling stroke alerts and those sorts of things. So we'll start with just a little bit of background and we'll go through this part pretty quickly. So just guesses, where does stroke rank on the list of most common causes of death in the US?
Second.
So second's a good, I heard a fifth, and second's a good thought, but it is the fifth most common cause of death in the US. Someone has a stroke every 40 seconds, every 3.5 minutes, someone dies from stroke. Lots of strokes are recurrent. Having one stroke makes you at higher risk of having another. As you guys know, it's the leading the cause of long-term adult disability, and it's the leading diagnosis for transfers from the hospital to LTACs and rehab. And very few strokes will resolve completely without any noticeable deficits, only about 10%. There are some risk factors for stroke to think of. The first ones are kind of the unmodifiable ones. The big one is patient age. I mean, you can't modify that. And stroke risk certainly increases as you get older. The caveat with that is younger people tend to have more debilitating strokes, a lot of times because they're hemorrhagic stroke and not ischemic stroke. Higher risk in men, but mortality is higher in women. Lots of reasons why, some atypical symptoms, some lack of getting to healthcare in time and those sorts of things. 2 times higher risk in Blacks versus whites. So those were kind of some unmodifiable risk factors. What do you think is the most powerful modifiable risk factor, something you can change? Hypertension, that's the big one. So over time, hypertension, putting pressure against the walls of those small vessels in the brain and in the neck can make them prone to thrombus formation and plaque formation, and ultimately either clot or hemorrhage. So, but there are lots of others. Heart disease, atrial fibrillation is the big one. If you're in AFib, particularly not treated with an anticoagulant, you're at risk for popping off an embolus that can go to the brain and cause stroke. Diabetes for the same kind of vascular reasons as high blood pressure, cholesterol, smoking, all of the fun stuff, basically. So we're going to talk today about ischemic stroke, and that's where, basically blood is interrupted either by thrombus or an embolus, or sometimes it can be by what we call hemodynamic failure, meaning you take a patient that, maybe has high blood pressure normally. So their brain is used to their blood pressure being very high. And then for whatever reason, their blood pressure suddenly drops. It's medicine we give them or trauma. And just that lack of the normal blood flow can cause a stroke as well. So what do we mean by thrombus? Usually that's due to a plaque that is formed in an artery. The plaque becomes unstable, it kind of unroofs and exposes a lot of very powerful pro-clotting material. And so a blood clot forms there. It's the same sort of thing that we see in heart attack. And embolus is usually a clot, again, from like atrial fibrillation or something along those lines. Sometimes it's air, if someone gets an air embolism, sometimes it's cholesterol from a long bone fracture, but those are much rarer. And then within the category of ischemic stroke, there is this thought of large vessel occlusion, and it has gotten a lot of attention over the past 15 or 20 years because it has opened up new pathways to treat stroke. So what do we mean when we say large vessel occlusion? Basically, it is these arteries here, and we're going to talk about them all separately. So it starts with just kind of a general understanding of the cerebral blood supply. So you have in the anterior circulation, your carotid artery that supplies the anterior portion of the brain, and then posteriorly, your vertebral arteries that form then into the basilar artery and the posterior portion of the brain, your brain stem, your cerebellum, those sorts of things. So does anybody, it's maybe kind of hard to see in the back, but does anybody know what this structure in the brain is called? Circle of Willis, yes. So it's kind of a circle. It's discovered by somebody named Willis probably. So it is a circle of Willis. So the circle of Willis kind of sits here in the anterior portion of the brain. You have the carotid arteries that are coming up from the neck into the middle cerebral arteries that then all interconnect into the circle of Willis. And then from the posterior side, you have the vertebral arteries coming up into the basilar artery, which again supplies the cerebellum and brainstem, and then into the circle of Willis as well. So it's an important structure when you think about aneurysm, because a lot of aneurysms form in the circle of Willis and cause like subarachnoid hemorrhages. But we're talking more about ischemic stroke today. So what about the anterior cerebral artery? If you get a clot in the anterior cerebral artery that causes stroke. So it's not a hugely common stroke to see. And it can be a little bit difficult to diagnose because sometimes these patients will only present with leg weakness and numbness. And it's kind of hard to decide, is this a stroke or is this a lumbar problem? It's more helpful when it's a little bit of a larger stroke and they may have some of these other signs like, just kind of some clumsiness with ambulation. They can have some mood and personality changes, some speech slowness because it involves the frontal. So there's just a graphic representation of a section of the brain and what the anterior communicating artery supplies. So not a huge area, but still quite debilitating stroke. Now, the middle cerebral artery, those big arteries that come off of the carotid initially, this is the big one. This is the stroke that you immediately recognize. They're very, very sick. They're very, very debilitated. They have the high NIHSS scores. They've got the weakness on one side. They've got the aphasia or neglect, the dysarthria, the gaze deficit. And, very severe, these strokes, they'll just be completely hemiplegic. They won't be moving one side of their body at all. These are usually fairly easy to recognize. And it's a large area of brain. It covers a large territory. That's why. Posterior cerebral arteries and posterior strokes in general are the bane of our existence a lot of times in the ED because they can be really difficult to identify because a lot of them just have kind of dizziness or vertigo and it's hard to sort out, is this an inner ear problem? Is this a true brain problem? But if it affects, the visual center of the brain as well, they'll have a visual field defect, like they'll not be able to see one corner of their vision or one half of their vision, depending on what area is involved. And a lot of these patients will also have a headache and even vomiting sometimes. And so that's the posterior cerebral artery supply. Again, not a huge area, but still a very debilitating area. And then you've got the vertebral and basilar arteries, which again are the midbrain, the cerebellum, similar sort of thing as a posterior cerebral artery stroke. They'll have dizziness, they'll have ataxia. They'll also have a lot of cranial nerve signs, meaning, maybe they've got, drooping of the eye, maybe they've got a lack of ability to move their eye. Maybe their tongue is deviated one way because a lot of the cranial nerves come off of the brain stem. So if that area is affected, they will have those signs. In a really bad vertebral or basilar artery stroke, you'll get what's called the locked in syndrome. And that's just basically where a person is conscious, but has no real voluntary movement at all. So it's really a horrible, horrible disease process and not much that you can do.
Are they awake enough to know that?
Yes. Yeah. So there's just a visual representation of the basilar artery. And then we've got these small arteries that aren't pictured here, but like come off of the middle cerebral artery into like further out sections of the brain. They're small, so they don't cause a very big stroke, but they cause a fair number of strokes. It's probably the most common type of stroke out there. And they cause what we call lacunar infarcts. And some of these can be just kind of primarily sensory strokes. So some people may come in with just kind of arm numbness, and it ends up being a small lacunar infarct in just the sensory area of the brain, but a lot of them are silent. You know, we scan lots of people's heads and we will all the time get lacunar infarct results, and patient may never know that they've had a stroke or have no symptoms. So a lot of these can be silent. And this is not a large vessel occlusion. That's just another representation of cerebral blood supply. So I just wanted to spend a minute talking about the penumbra because this is a really important idea in stroke management. So when someone has a stroke, they will have an area of brain where they have lost circulation. That area of brain will never come back. It's dead. It will never come back. But around that area of brain is this larger area of tissue that is at risk for dying. And it may already be dying, but it is salvageable. And so when we think about treating stroke, this is the area that we focus on because we want to save this penumbra so that this doesn't become that big. And that is why stroke is such a time-sensitive modality that we treat. So this is all just talking about that. Basically, just what I talked about. So let's talk a little bit about ischemic stroke. So from the EMS standpoint, it's a big deal. It's such a big deal that the American Heart Association and the American Stroke Association have come together to put a policy statement in place dictating how EMS should take care of stroke patients. A couple of these things, I'll kind of go through this pretty fast, but obviously if you have a choice between ALS and BLS, you want to dispatch ALS. They recommend all of these different times, which we typically do well with. Transport to an appropriate facility down there at the bottom. In our case, every hospital in this area that you can transport to basically can do the same emergent things. They can get a CT, they can get a CTA, and they can give TPA. So you don't have to choose between taking them to a primary stroke center versus a thrombectomy stroke center because there aren't any in this area. So you basically take them to the closest facility. This is just a map of stroke centers in Indiana, and you can see down in Vigo County, both hospitals are primary stroke centers for the state, which means that they can do those things: CT, TPA, neurology consult. They have protocols in place for admission and those sorts of things. But even your critical access hospitals, they can still do CT, CTA, thrombolytics, and transfer the patient to a thrombectomy center if needed. So I think you all know the Cincinnati pre-hospital stroke scale. It's not perfect, but it's the best stroke scale out there. There's a one from Los Angeles too that's okay. You're all really good at this, so I won't spend a lot of time on this. We talked about the vision, aphasia, neglect, the VAN score in the field to determine large vessel occlusion. So in addition to a positive Cincinnati stroke scale, if a patient has one of these signs, a gaze preference, you hold up a pen and they, mumble or can't tell you what it is, or say that it's, a watch or something. Or if they have neglect, they're not recognizing one side of their body or objects on one side of their body, that would be a positive VAN. Again, not hugely important here, but if you're like in Indianapolis and you're deciding, do I take a patient to, a hospital that doesn't have a thrombectomy center versus a hospital that does, if they were positive with VAN, you would want to take them to the thrombectomy capable center. Again, this just kind of is all of the things that the Cincinnati scale typically shows you as far as recognition. The big one on here for me is vertigo. Again, vertigo can be a sign of stroke, spinning vertigo. And what we really look for is vertigo +1, meaning vertigo plus a severe headache, vertigo plus numbness in the arm, vertigo plus a vision deficit. That is a real red flag that there could be a posterior circulation stroke. And all of these, again, communication. Again, early communication is key because time is brain, number one. We all know that. And number two, the hospitals, especially the stroke centers, are really, they're really graded on the time that the patient gets there to the time that they get CT, to the time they get TPA, to the time they get transferred. So as early recognition that we can get is very important and very helpful for us. It helps us to get CT ready, the stroke team, all of those sorts of things. And the goal really is immediate door to CT on arrival. So this is kind of a, what am I thinking sort of question, but in the emergency department, when I'm getting a call and you say it's a stroke alert, the first question that's going through my mind is this patient a TPA candidate? Because if they're a TPA candidate, then we're going to have to worry about getting the medication mixed, be sure we get the teleneuro cart set up, immediately. So that's a huge question, really the number one question, for me when you're calling in the stroke alert. So the two major questions, last known well, because if it's within 4.5 hours, they're a candidate for TPA or thrombolytics. And then if it's within 24 hours, they may be a candidate for interventional neurology if they've got an LVO. And if they're on any anticoagulants. These are the two big ones. Because if the last known well is greater than 4.5 hours, or if they're on any of the anticoagulants, they're not going to be a TPA candidate. So I don't have to worry about, getting pharmacy or getting TPA or, I can slow things down a little bit in that circumstance.
Can I chime in on that?
Yeah.
So one caveat, please try and find out when was the last time they took their anticoagulants if they're on it. We caught somebody, thankfully, actually to our pharmacist, Ashley, she went in, I had this guy come in, he was on Eliquis or Xarelto, but was not compliant with it. Initially, we thought he was compliant, and then she found out he hasn't been compliant for 2 days, so he actually became re-eligible for TPA. And we gave him TPA and then got an LVO and got him out of here. So if you can find out if they are taking it, when was the last time they took it?
And the same with Coumadin, if they're on Coumadin, if their INR is 1, they're still going to be a TPA candidate. Again, so last known well, and then again, if they went to bed and were normal and woke up with a stroke, we need to know what time they went to bed. And if that requires you to talk to the family, the friend, the dog, the neighbor, you can, that 30 seconds or a minute to do that, that really, really helps us because we cannot do anything with TPA until we know for sure the last known well. Again, paperwork, last known well, any anticoagulants, those are the big ones. So again, in the primary survey, the big one is finger stick glucose. Hypoglycemia is a huge stroke mimic. So that's the most important thing from a laboratory standpoint. Your usual tests otherwise, we want to avoid hyperglycemia. We want to avoid hyperoxia, hypoxia. So just kind of your typical, ABCs as far as that goes. So EKGs are helpful with stroke. I mean, this one on the left, you can tell here, no clear P waves, kind of a wavy amount of P waves. This is AFib. So if a person doesn't have a history of AFib and then they present with this EKG and a stroke symptom, that's a big red flag that it probably is a stroke. This one on the right is what we call cerebral T waves. It can happen especially in subarachnoid hemorrhage. Basically, we think from a catecholamine surge. That's also can be a helpful sign with stroke. So blood pressure, I just want to bring this up briefly and we can stop here. We'll look at a couple of CTs because a lot of people question what to do about blood pressure with stroke because, if you've got a really high blood pressure and you drop that blood pressure, you may actually, decrease somebody's cerebral perfusion pressure. So it can be dangerous to drop blood pressure in a stroke. But blood pressure control can be beneficial in a hemorrhagic stroke. And you really don't know when you're in the back of an ambulance or when I'm first seeing a patient in the ED, if it's a hemorrhagic stroke versus an ischemic stroke. Also, blood pressure control is generally needed for thrombolytics. So we can give TPA to a patient that's got a blood pressure of 230 systolic. So my thought is, and Matt, let me know what you think, but if someone has a severely elevated blood pressure, like greater than 200 or certainly 220 systolic, giving them a one-time dose of labetalol is not a wrong thing to do, because if it's a hemorrhagic stroke, it's going to help them. If it's an ischemic stroke, it's probably not going to drop them too far, and it may get them down into that range where we can give them TPA sooner. So I would say a one-time dose is reasonable. If you feel like you need to give more than that, I would put it on medical control. To the side.
That's right.
And again, saving the penumbra, that area around the infarct, likely means that you need to allow for permissive hypertension, meaning that elevated blood pressure will help to save the penumbra. And again, there are a couple of studies that show that actually aggressive blood pressure control in stroke is associated with worse outcome. So don't sweat the hypertension in a stroke patient too much unless it's severe. So again, the definitive treatment is thrombolytics within 4.5 hours if they meet criteria. The problem with thrombolytics is these are the rates of reperfusion after thrombolytics on angiogram. So it's not great. If someone has an MCA, that patient we talked about earlier had a M1 occlusion, only about 1/3 of those patients will have reperfusion after TPA. It's much worse if you have an internal carotid artery stroke. So that's why we've got the intravascular treatments, the thrombectomy, and those sorts of things. And that's what patients have to go to Indianapolis for that we don't do here. And again, these are just different thrombectomy procedures. They can suck the clot out. They can stick a net basically into the clot and expand it and pull it out that way. It's kind of up to the interventional neurologist, but that's within 24 hours of symptom onset with a large vessel occlusion. So this is a normal CAT scan of the head. This CAT scan is a couple of days after a stroke. So this is an evolving stroke. All of this is edema. So this is an MCA stroke. This person has clotted their left MCA a few days ago, and now all of this area is dying. It's too late to save any of that. And this is what it looks like several months to years later. They just lose that entire MCA distribution, and you can imagine that is pretty devastating. All right, so that's it. We blew through that pretty quickly. If you have any questions, you can ask me, or you can always email me, or we can talk about it in person. But all in all, I think you guys do a great job with stroke and recognition. Keep up the good work.
Thanks, Zach. Thank you very much. Anybody have any questions? All right, so a couple things I want to talk about, then I'll let you all get out of here and everybody can get offline. This year we are going to go back to doing our EMS skills days. These will be days where you can actually come in and do every station and get all your skills you need for the year, for 2 years, and get it all in one time. September 5th, 6th, 7th, and 8th, all 4 days will be 9 to noon. They'll be at the simulation center. It'll be the same stuff you do. You'll come in, sign in, go to the stations, come in groups, pairs, whatever you want to do. Come in and by yourself if you need to get those. They'll all be held at the simulation center. It'll be similar to everything we've done all the past years. We just didn't do it last year, so we're going to be doing it again this year. Okay. For those of you that want to get credit online or here, whatever you need to do, here on the sign-in sheet, make sure you sign in. You're going to get credit for it. Scan the barcode. There's some questions on there. Answer the questions, and then I will get a report that tells me who's taking it, and you'll get credit for the A&R that way. Okay. There's a link there too. You can try to click on the link, highlight it, and copy it or whatever you need. Something else I wanted to talk about is EMS week. EMS week, we will be hosting, Union Hospital will be hosting the luncheon on Wednesday, May 17th. Probably go from like 11 to 1, 11 to 2, something like that. And we'll have out in the under the tent. I'm sure it'll pour down rain because that's what it does. So hopefully it doesn't, but it's what happens. Last year at least, right, the regional got a little bit of rain last year, so that was interesting. So this year we'll be holding on May 17th, and then on May 18th, keep this in mind for anybody that wants to. I'm going to be hosting an EMS one-day conference at the Lansbaum Center. It's going to be all day from 8 a.m. breakfast from 7:45, and it should go all the way to 4 o'clock or 4:45, depending upon. Going to get a minimum of 7 hours of continuing education for free. We have the state EMS medical director coming to be a keynote speaker. Dr. Malm is going to speak. We're going, Vituti's been very nice. They said that they would buy breakfast and lunch for everybody that shows up. So that's nice for them to sponsor that for us. So it's just something for me, for you, your people to present to you as an EMS group to say, hey, you need some continuing education, come visit. It's EMS week anyway, right? So the 17th is lunch. The 18th will be the EMS conference, the one-day conference. It'll be at the Lansbaum Center. Breakfast will be from 7:45 to 8:45. We'll start doing introductions about 8:45 and 9 o'clock. Dr. Yes is going to speak. So please plan to be here. I'll have a flyer out, get it sent to everybody so they can get it put up. You will need to email me or call me and tell me you're interested. I will get you on the sign-in list and we'll just sign up when you get here. That's basically the best way we can do that. So there'll be handouts and everything else that day for everybody that comes to the conference. But other than that, does anybody have anything they'd like to add? Zach, anything else you'd like to add? If you have questions, comments, or concerns, let me know. Otherwise, have a great day and thanks for your time. I appreciate it.
Just sit on that and.
Sheriff's.
There.
It's part of the.
And
What
they-
do you think?